So basically the way these works is on this particular brand, there's a couple brands, that these unidirectional barbs, they start going in opposite directions in the center. You sew out both ways, and the barb makes it so the suture can only go one way. So every throw that you make, this barb catches, and it's like a knot. So we use knotless surgery, which is very cool. So we looked up a series of patients, 500 patients, that 250 we had closed with traditional sutures, and 250 patients which had closed, Macworld and PC collide, and we have a sideways picture. Okay, so, oh no, here we go. Turn your head to the side. So, so the way it works, you throw the suture in both directions, load it, and this is my one of my PAs that's closing in this layer. So, and then as you pull, it cinches, and then it stays, right? So that's a side view, and it's a little crooked. Sorry for the Mac PC thing, but basically it's knotless suture, and what I'll show you is really very cool. So the operative time in the series that we looked up, this was 7 years ago, so a while ago, we dropped our OR time, and this was even skewed. We dropped our OR time about 5 minutes, 4 minutes in this series, but it's about 5 minutes quicker to use this versus traditional knots, because you're not stopping and tying every throw, right? And then we had an overall lower complication rate. Major complications were less, and fewer complications overall in this group, and that's because you get a better seal. Instead of having 10, 15 vicryls, which all have little holes. So instead of like a button fly gene, you've got a zipper gene, right? Nothing's getting in or out. So I have daughters, I won't go any further with that. But we had the effect was even bigger in larger BMI, younger patients and male. So in the harder cases, the more you struggle, the less you struggle with this kind of suture. A technical tip that we've shared with each other is we open and close in flexion. That makes it so we close our knees in 105 degrees of flexion. So when you inherit them in therapy, they were closed in flexion. There's nothing going to happen to this patient. You can bend their knee, and we tell them that now swelling will limit flexion, but the repair on the inside will not be jeopardized by bending this knee. So the analogy would be grab your pants and tighten up your pant leg, and then try and bend your knee, and it groups it, it grabs it. So it works. It's been proven in studies, and it's a technical tip which is really helpful. We've looked at our data in lots of ways trying to improve things, and as we have, this is our inpatient data. Nausea, vomiting, pain control, and hypertension, dizziness are the reasons that patients don't ambulate right after surgery. We have a goal of 30 feet ambulation right after surgery, and that's an attempt to get them moving, right? So a few years ago, we looked up, we did a randomized prospective study on using Decadron, so steroids, in and around surgery. And in this, we took 3 groups, and basically the 3 groups, one didn't get any steroid, one got steroid at the time of surgery, and a third group got steroid 24 hours after in addition. So two doses versus one versus none. And we gave them pain meds and anti-nausea medicine afterwards. We tracked all kinds of outcomes looking at how they would do, and we used the visual analog score for pain and nausea. The nausea is my favorite. And then the pain one is not happy either, right? So really awesome results that we got from this study. So we tracked day of surgery ambulation with our non-steroid and steroid group, and you can see a statistically significant difference in our steroid group. Day 1 ambulation, the second group hadn't gotten their second dose, so they behaved the same, but statistically significant differences in day 1 ambulation. And then day 2 ambulation, again, statistically significant differences. Okay, so that's just ambulation. Range of motion, we had a statistically significant difference in range of motion in our steroid group versus our non-steroid group, and this is in 1 day. Pain medicine use, so our use of a PCA pump. So we put everybody on a PCA pump so they could self-administer for this study, and we had significantly less use of narcotics in the group that had steroids, okay, in the PACU, but also just their own self-administered. In the oral narcotics, so this is we converted everything to hydrocodone or Norco equivalents, and even though whatever they were getting, we converted it to that. And we had statistically significant differences in narcotic use pretty dramatic. I mean, look at the difference. Our patients were taking 1/3 the amount of oral narcotics in the steroid groups compared to the non-steroid group. So keep that in mind. They're getting way less IV narcotics from their PCA, way less narcotics from their pill, right? And with all of that, their visual analog score ratings were statistically significantly better. So they're taking way less pain, they're walking further, they're taking way less pain medicine, they're walking further, and they're rating their pain scores at statistically significant differences, which are pretty dramatic. So you look at this visual analog score difference of on a scale of 1 to 10, a 4.5 versus a less than 1. Really awesome stuff. Nausea, right? Post-op nausea is a reason why people can't ambulate. Okay, so PACU, day 0, day 1, day 2. Again, these are dramatic differences. These are reasons why people fail. They come to therapy and they can't function. It's because I feel lightheaded, dizzy, nauseous, right? So this is a pretty awesome findings. Length of stay. So this is a historical study because we're showing you old data. I mean, it's when we did it. 4 days for the control group, 2.7 for the one dosing, and then 2.57. And the reason this number isn't even bigger is because we were just telling people you stay 2 days, right? That's what we were doing at the time. So and we were letting people go home day 1 in that period of time, letting them go, but not really coaching them to it. And I'll speak to that in a second. So basically, you can see all the numbers, dramatically different. Okay, so infection, right? Infection's a really big deal, and that affects our outcomes and our recovery. So risk factors, we've heard them before, and they are all of the ones that we know, okay? Right. So what do we do? Look, we do a list of things on every patient to prevent them from having infection. And we do it on every patient, right? So we screen them, we go through a checklist, and then we obviously work very carefully in the OR, right? Tight closure, no drainage, that's a really big deal. I don't want my patients draining at all. So then we looked at basically the use of local antibiotics versus in supplementing the IV antibiotics. And there's tons of literature which supports this in the foot and ankle, in the spine world, and in the pediatric world. And so basically we took that knowledge, stole it from other disciplines, and then applied it to this. And we did a retrospective review of using vancomycin powder in the wound at closure. Our control group, now this is all comers, I'll break it down. Our infection rate in the control group, which was the cases before, out of 824 cases, we had 13 infections, which is a 1.5% infection rate. It's not really great, I would say. Now, if you look and break it down, our primary numbers were pretty good. Our primary hip was 1.6, and the larger your number gets, the more significant that becomes. But our revision numbers, you know, when you're doing revisions and you see horrible complications of metallosis, and we'll get into some of those things on revisions on the next subset, there are big problems. So we took our next year of patients and had 4 out of 816, and this is with 3-month follow-up. So anything basically in the acute episode of surgery. So that's a dramatic difference, right? So, and breaking those down, we had no infections in our revisions in that group. Really awesome. There's no way you're gonna do surgery and not get infection. It's impossible. You're not gonna do surgery on people, send them home, and have all of the things that happen with them and not get infection. It will never happen, right? But you know, getting it down as much as you can really makes a big difference. So in summary, 13 out of 824 before, 4 out of 816 before. So pretty dramatic stuff. This has all been presented on a national level, all of this data you see. And then one of the last studies, which I'll show you, is we basically looked at IV versus PO Tylenol and trying to figure out what makes our patients feel better. And IV Tylenol, we were studying it because it makes sense. It crosses the blood-brain barrier. So basically, the higher you can get this initial spike, then it makes your mean cerebrospinal fluid levels jump up. So you're trying to get your CSF levels. Tylenol is a centrally acting medicine that we really don't know the mechanism of how it works. So you're trying to get your serum levels up so you get a CSF spike, and that turns into a good pain relief. So IV gets you a bigger spike. So the reason we looked into this was we thought it was good. We really didn't know for sure. And the price of Tylenol went from up to $33 a dose, whereas PO costs a nickel. And they took it off formulary for us without us really having say. So we did this study. And we looked at 120 patients where we had basically very similar to there's a lot of words here, very similar to what I just described with the Decadron study, in that half the patients got PO Tylenol and half the patients got IV Tylenol. And the short of it is that the IV Tylenol made a slight difference in their visual analog score and no difference in the amount of narcotics they took at all. And really, it was a statistically significant difference in their visual analog score without probably much clinical significance to that. So because of this study, in trying to figure things out, we've gone away from using IV, but we use PO Tylenol on everybody. And there's no other study in the literature that has done this yet. And this has been presented on a national level also. So what do we do in rapid recovery? So these studies that I've just given you, they're all, rapid recovery is not we do one thing. It's you do about 50 things to get the patient ready. And the biggest thing that you do is education. So Mike, in his Total Knee Talk, went over this, but basically there's a lot of in-office education. So I spend talking to them. I have PAs in the office with me, I have a nurse with me. They all spend time talking to them. We make everybody go to a total joint class. That's an hour of education. For my knees, all of them go to at least one therapy session, and for our hips, it's debatable, but there's less education obviously on the exercise side of a hip. So we give them a booklet, that has lots of information in it. They look through it. There's website information. I think prehab makes a big difference. In short, you're setting expectations. You talk about the home environment, all of that, right? And then pre-op screening, it's about patient selection also. So, we screen our hemoglobin A1C on everybody. If they're diabetic and their hemoglobin A1C is above 7.5, then I don't do the surgery. The number of screening in that is 7 or 7.5. But we screen every diabetic. And if they're elevated, we don't do the surgery, and we give them a pep talk, and they come back in 2 or 3 months with a better controlled hemoglobin A1C or better controlled blood sugars. And what does that do? This empowers the patient. This is not, it helps their knee. I always tell them it helps them too. We check their nutritional status on everybody, vitamin D levels. You'd be amazed in Ohio how many vitamin D levels are low. Everybody gets a bottle of chlorhexidine scrub. They wash before surgery. Seems really simple. It's not. Some people don't understand that you wash, right? And then we do a mini bowel prep because, as Mike alluded to earlier, constipation afterwards with narcotics is a big deal. So we do a mini bowel prep, and some people don't like that, but they also, the number of people who wind up in the ER impacted for me is pretty low. Okay, so current protocols which we have around are multifactorial again. So, there's a lot of things that go into a rapid recovery, and I think a lot of this is a lot of it. There's evidence-based literature based on everything that I have up here, and you have a flash drive, so you can write it all down, but it's on your flash drive. So a pre-op NSAID, pre-op Tylenol, pre-op PO, long-acting narcotic, Zofran, scope patches plus minus. Everybody gets Decadron, as we alluded to. Tranexamic acid is a really big deal. So this is a game changer for me. I haven't done a study on it, I didn't present anything for it, but this reduces the amount of intraoperative and postoperative blood loss, which really turns into a pain issue because you don't have as much of a hematoma. But I also know that there's some systemic anti-inflammatory effect which we are not capturing. Anyway, IV TA is a really big deal. Excuse me, I jumped ahead there. Okay, so I do not use Exparel. I use the standard bupivacaine with epinephrine. There are studies that show it doesn't, that there's no big difference between the two. Lots of them presented in the last year, and I've seen it myself clinically. We use the Vanco powder. Everybody gets an IV PRN order, and then everything that you see listed here. And for home, we send them with a PO narcotic. Everybody gets an NSAID. I've switched to this one because doesn't require a pre-cert, and it's generic and it's cheap, right? And then aspirin. I do aspirin for all my DVT prophylaxis as opposed to an injectable for the bleeding risk complications. And there's lots of literature to support everything that's on here. So this is all evidence-based, that is sound, and there's lots of ways to skin a cat. That's not to say that this is the only way, because it's not. But there's everything that we do, we try to back it up with data, okay? And with this, we have day of surgery ambulation numbers, which are 90%. Hospital length of stay is 1.8 for us right now. I've been doing outpatient surgery in a surgery center that does not have a 23-hour stay, and we're opening our second of the orthopedic one surgery centers, which will both have 23-hour stay capabilities. So, patients can have an outpatient surgery with confidence, with good screening criteria, go home same day, and be very safe in doing so, and there's a fail-safe if they can't get out that day. The truth is, of the failures, I've done a lot of outpatient surgeries, and in a fail, we only had one person who has failed that 23 hour, the immediate discharge. So with rapid recovery protocols, it isn't about giving one drug. It's really about a team effort, and it's multimodal, and it requires effort on the front end. So, and then you get results on the back end. Okay, so that's my fun stuff.